Good morning, everyone. Thank you so much to the Scientific Committee for this opportunity to present my last year's paper as a keynote in this session. So it's titled as Transconjunctival Intralevateral Triamcinolone for Upper Lid Retraction in Thyroid Eye Disease. Thyroid disease, as we know, is an enigma. The most common disease that affects the orbit. It is complex. It is poorly understood still, and it has an autoimmune pathology is what we know. Because of the autoimmune pathology, there's growth in the orbital fibroblasts, which can lead to multiple complications in these cases, naming lid retraction, myopathy, proptosis, and optic nerve dysfunction. The natural course of the disease is also what we are aware of. It has a dynamic phase, which is the active phase, and a static phase, which is the inactive phase of the disease, which is popularly called as the Rundle's curve. And the most common eyelid symptom that we come across here is eyelid retraction, which is seen in almost 90% of the cases. And the mechanisms that have been explained for this retraction is probably the overaction of the levator and the molars because of the increase in sympathetic tone, fixation duress, levator hypertrophy, or the muscle contractions or fibrosis, and abnormal adhesions between the levator and the surrounding structures, scarring or inflammation of the septum and the anterior lamella. So what are the challenges that we face in these cases? One is the functional challenge, that is the lag of thalamus and the exposure keratopathy that ensues, and the cosmetic challenge, of course, because of the psychosocial impact that this retraction can have on these patients. And what are the management options in hand for us? They are either surgical or non-surgical. Surgical options, we are very well aware in thyroid eye disease, we cannot touch when it is in the active stage. So in active stage, we have to wait for that stage when the fibrosis has set in, and then only we can go ahead with the surgeries. And the non-surgical options I have also listed here, like botulinum or hyaluronic acid gels or triamcinolone injection. So when we look at the levator recession papers that have been published, the mere list of the papers can actually tell us that there's no standard protocol that exists for these retractions, and no standard protocol treatment has been devised. And even with our experience, we know that patients are not very happy with the contour and the lid margin that they, lid crease that they get. And the non-surgical options have also been studied, like Botox or hyaluronic acid, and comparison studies in between them. So these are the questions that we actually think when we think about these management options. And keeping those questions in mind, we try to evaluate the role of transconjunctival intralevator injection in the upper eyelid for these cases. 37 eyes of 22 patients was involved, and it was a retrospective interventional case series, and wherein we gave the injection in subconjunctivally in the OPD setup according to the dose that we required. And this is the analysis that we got. The mean age was 46. Females were predominant, and bilaterality was seen in 13 of our cases. Mix of hypothyroid and euthyroid cases were present. Interestingly, we had more inactive TED cases in our series, that was 16. So 2 index cases. This is an active thyroid, which is, she was an IVMP, and after her 3 cycles, we decided to give, we do all the measurements when these patients come at every visit, and we note them down. And while her IVMP doses are going on, after the 3 cycles, we give her 1 injection of upper lid triamcinolone acetonide. And this is how she basically, this was the result that we got after 1 injection for her. And this is the measurement that we did after the injection. This is a second index case, which is a case of inactive disease. And again, we did all the measurements in this case. And he had to receive 2 injections, but he also gave a gratifying result. So these are the measurements after his second injection when it settled down. So the mean number of injections that we got was a range of 1 to 4. The mean average dose was almost 23 milligrams, and time to maximum response was 37 weeks. And all the measurements that we did, MRD1, PFH, superior scleral show, and the lag of thalamus showed a statistically significant response in our case. And there was no regression from the maximal response, and only 1 patient had a transient increase in intraocular pressure, although it's a subconjunctival injection. But still, because it's steroid, we actually measure the pressure properly in every case, and it settled down after giving anti-glaucoma medicines. And these are some of the other cases where we got good results in our series. So all the questions that we set out with to answer, we could answer with our series that we were studying, that it can be used in active and inactive cases. 1 to 4 injections might be required. It has a long-term effect. Basically, it is stable, and more than 6 months we had seen, and there was no regression. There was no local side effect, no ocular side effects. And in both functional and cosmetic cases, this can be used. A handful of case series exist, none from our country. So this is the study from our country, wherein we have studied in 22 eyes of 22 patients and 37 eyes. And the mechanisms that have been proposed that I dug into in the literature has been either anti-inflammatory effect, but this actually is more true for when the active disease is going on, because that is when actual inflammation is going on. And second thing can be aponeurotic detachment or thinning of the muscles. So I would like to conclude that we have many things in the arsenal to treat these patients. It is very challenging. So keeping this injection in hand gives us an opportunity to kind of like treat these patients adequately, even when the active or the inactive disease is going on. These are my references. Thank you so much.
Thank you, Dr. Shefali, for the excellent presentation. Just one question. What is the technique of injection? How did you inject it?
So we evert the lid on the DMRs in the OPD setup itself, and it's subconjunctival. It's not intralevator, but it kind of like just goes subconjunctively
Like
and
a Botox
sits over.
injection?
No, sir, it's a triamcinolone acetonide.
Like a Botox?
Like
just
a Botox,
you
yes,
got it
sir.
in, just
Yes,
subconjunctival.
yes,
What
yes.
is the dose?
So dose according to the retraction that we got, but generally we kind of give either 1 ml, that is 20 milligram per milliliter of TA, or we can even go 0.5 to 1 ml.
Do you have any location? Do you give it laterally to decrease the lateral flare, or do you give it
So
centrally?
generally what we do is like go inside to the medial extent of the lid and kind of like withdraw the needle as and when we are giving the injection, and kind of it diffusely sits inside the
Did you monitor the
subconjunctivally.
intraocular pressure? For how long did you monitor IOP?
IOP, sir, every visit, sir. Every visit
For
we
how
do.
long?
So till anyways, as a general routine also
2 or
we
3
measure
months?
yes, sir, yes.
And there was no IOP spike at
No
all?
IOP, sir. It's not like the intraorbital injections that they seem to have more increase in the IOP. This is subconjunctival. Okay. There's no leakage that we see. Even if there's a leakage, we kind of like put a bud and don't allow it to go to the ocular
And they were
surface.
getting parallelly IVMP also, is it?
In active cases, sir.
In
Active cases, we start off with the IVMP, and after 3 cycles, when we know that it is not settling down because of the retraction and all is not responding to the IVMP, then we give after the 3rd cycle. 3 weekly cycles
And
we
if you
give.
want
That is
to
our
re-inject,
dose.
when did you re-inject? How many weeks later?
Sorry, sir?
If you want to re-inject, give a second dose of...
So 3 weekly the patients are coming, but we generally re-inject after 6 weeks.
6
But
weeks.
if we see that the depot of the drug is already there, we kind of like can see that yellowish sheen from the skin surface, we can delay it also. So ideally 6 to 8 weeks.
Thank you so much.